Thank you. Thank you for the organizer to invite me to give this talk on fusion in gastrointestinal tumors. So I divide my talk in two. So first I will discuss some technical issue for detecting fusion, and then I will give you my best of the different fusion in gastrointestinal tumors. So this is my disclosure. So what is a fusion gene? So you have two genes, a gene A and a gene B, and there is initial event, genetic initial event, which is a break into gene A and into the gene B. And the gene A and B can be in the same chromosome or in two different chromosomes, and there you have inversion or a translocation of these two parts of chromosome that bring together, for example, the proximal part of the gene A to the distal part of the gene B, creating a chimeric gene, a fusion gene, putting together a part of the gene A and the gene B. And then this gene can be transcribed, and you obtain a fusion transcript that could be translated into a protein, and this chimeric protein can induce cell transformation or cell proliferation. How it can be detected? You can detect this by whole genome sequencing and not exome sequencing, or by RNA sequencing. But this method is not designed for a diagnostics purpose and the routine diagnosis. So you can also use FISH for fluorescent in situ hybridization. And for example, this is an example for detecting a known fusion. You have your usual suspect, for example here the gene B, and you have a partner of this gene, the gene A. So you design a probe, a green probe for gene A and a red probe, fluorescent probe for gene B. Since these two probes are far away from each other, you have in normal cells two green dots. And because you have two copies of the gene A in your normal cells, and you have also two red dots because you have two copies of gene B. So in case of a translocation and a fusion genes, you put together the two probes and you obtain a yellow dot because these two probes are very close, each one to the other. So you have a superimposition of the two probes. If you don't know the partner of your favorite genes, you need to develop what we call a break-apart FISH, using, in fact, two probes that are focusing on the same gene, one on the distal part of the gene, and one in the distal, proximal and the distal part of the gene, sorry. So since these two probes are in the same genes, they give you your yellow spot, as already explained. But if you have a break inside the gene, you will separate the two probes and obtain a yellow, a green and a red dot. Just is a surrogate markers of the fact that you have a break in your genes, and it's a surrogate markers of a fusion gene. You can also detect this fusion gene by RNA and molecular biology. So you have your usual suspect, the gene B, and this gene B can have several partners. Partners A, B, C, and an unknown partner X. And you want to detect all these partners because it's important to detect the fusion gene with your favorite or usual suspect gene B. So you have known partners and unknown partners. So you create from these RNA, cDNA by reverse transcription, and then you are able to amplify this gene. You are able to amplify it because you know the genes that are involved in the fusion, so you can design a primer for the partners of the gene B, and you can also have a partner for your usual suspect, a primer for your usual suspect. And you can amplify these genes and since you create a high copy number of the fusion, which is easy to detect by next-generation sequencing, for example. But with that, you are not able to detect the unknown partners of your favorite genes. So there is a trick to do that. You create, in fact, a chimeric gene by adding an universal primer oligonucleotide to your unknown genes. So since you know the sequence of these oligonucleotides, you are able to amplify this part of the genes and create by PCR a high number of these copies, and you are able to create the unknown gene. So these new techniques allowed to detect all the partners of a favorite gene that you want detected. So what is the potential targetable recurrent fusion gene in gastrointestinal malignancy? What we have learned from the last few years and what we can use that for treat patients. So in gastric cancer, there is a recurrent fusion that involved a tight junction protein, the Claudin 18 protein, with a regulator of small g protein, the ARH-GAP26 genes. So this lead to a protein here that have the transmembrane domain of the Claudin 18 with the Rho GTPase activating domain of the ARH-GAP26 gene. And this protein, in fact, have the inhibits Rho protein, and the inactivation of Rho protein induce cell proliferation and cell transformation in gastric cancer, and also the dissociation of tumor cells. So these fusion genes is in fact have a high prevalence, around 8%, in a large series of gastric cancer. And there is an enrichment for this fusion gene in the subtype of genomically stable tumor, gastric tumors, and is also associated with the young age of the patient, female gender, and also with the diffuse gastric type of cancer, with a high content in gastric signal ring cells, and up, as you can see here, of 20% in this subgroup of gastric cancer. These patients get no benefit from oxaliplatin and fluoromidine-based chemotherapy. Several other publications have shown that the presence of this fusion gene associating the Rho gap domain fusion with other partners have a worse prognostic, as you can see here in the series of more than 800 gastric cancer. Concerning hepatocellular carcinoma, it has been recently described fusion genes involving two genes, cyclin A2 or cyclin E1. And these two fusion gene is present in approximately 7% of hepatocellular carcinoma. And these two genes can be activated either by translocation or also by viral insertion, HBV viral insertion or adenovirus insertion. And this type of tumors is also associated with hyperproliferative tumors with poor prognostic, as you can see here in the survival curves. Its tumor is developed in younger patients and also in non-cirrhotic liver. These tumors, and it's important, are characterized by an inactivation of RB1 and PTEN gene, and also by the absence of the most frequent mutated gene, the beta-catenin and the mutation in the promoter of TERT gene, leading to the hypothesis that these fusion genes are in fact driver fusion gene for these subtypes of hepatocellular carcinoma. These subtypes of tumor are also associated with an accumulation of structural rearrangement, leading to the hypothesis that we could induce a synthetic lethality of this tumor by chemotherapy or PARP inhibitors. The third fusion that I would describe is those that occur in intrahepatic cholangiocarcinoma. FGFR2, that's fibroblast growth factor receptor type 2, are involved in different fusion genes, as you can see in the slide. There's a lot of different partners for these genes. But all these fusion include the ectodomain of the fibroblast growth factor receptors and the tyrosine kinase of these receptors. And the partners lead to the dimerization of these receptors, leading to the activation of this receptor independently of the presence of ligand. So you have a permanent activation of this receptor in this type of tumors. And you can have up to 45% of the cholangiocarcinomas that harbor this fusion gene, and is also associated, and it describes, in fact, subtypes of cholangiocarcinoma which has these specific alteration in BAP1 gene, the BRCA-associated protein 1. And of course, these type of alteration could be targeted by small molecules that inhibit the fibroblast growth factor receptor type 2. It has been recently also described in pancreatic cancer, a new fusion gene, a new suspect, NRG1, involving the NRG1 gene, which code for a ligand of ERBB3 and ERBB4 receptors, described by the previous speakers. And these fusion lead, in fact, to the enhanced expression of EGF-like domain of neuroregulin, NRG1, which serves as ligand for this receptor. So you have at the membrane of the cells, in fact, thanks to this fusion gene, a permanent activation of HER4 and HER3, ERBB3 and 4 receptors. So if you consider now the in fact, these fusion genes occurred in subtypes of pancreatic cancer, the KRAS wild-type pancreatic cancer, and I summarized 2 series that have been published, 64 patients, 8 patients KRAS wild-type, and 6 out of the 8 patients have this fusion gene. These fusion, and 4 of these patients have response to ERBB inhibitors. There is a large series that have been recently published on more than 20,000 tumors in different tumor types, and there is more than 600 pancreatic adenocarcinoma, 500 cholangiocarcinoma, and you can see the prevalence of this fusion of 0.5% in this large series. So if you consider, and all these occur in KRAS wild-type tumors. So if you consider that you have approximately 10% of pancreatic cancer with KRAS wild-type, you can estimate that the prevalence of this fusion gene is about 5% of KRAS wild-type pancreatic cancer. You have also now in colon cancer, and we'll finish the talk on colon cancer. So there is some suspect, ALK, ROS, NTRK, that could be, for which there is fusion that has been demonstrated in different tumor types, including colon cancer, as you can see here. And also RET can be implicated in the fusion. And these are more frequent for patients that have proximal colon cancer, and also half of these tumors show also MSI phenotype, and also for RET, you have an enrichment for KRAS wild type. This fusion confer worse prognostic, as you can see in this slide, in 2 series for ALK, ROS, NTRK, and also for RET. And there is also a large series that have been published last year at the ESMO meeting on more than, let's say, 18,000 patients tested both for these kinase fusion gene and also for MSI. You have, in fact, as you can see, if you take all these fusion genes together, you have a prevalence of 0.5% of the colon cancer that harbors this type of fusion genes, and it's largely enriched, this subgroup is largely enriched by MSI, with more than half of, or approximately half of these tumors that have also this MSI phenotype. These tumors harbor fewer mutations in P53, APC, KRAS, once again, and PI3 kinase mutation than the non-fused tumors. And this summarizes, in fact, all what we know of for gastrointestinal cancer. So you have the potentially targetable fusion gene, FGFR2, NTRK3, ALK, ROS1, RET, BRAF, and NRG1. And you can see that you can observe for all the tumor type at least 2 or 3 of these alterations at a frequency which could be low, around 0.1%. For the less frequent, but up to 45% for the most frequent in a subtype of tumors. And you have also these 2 fusion genes in the bottom part of this slide that could be targetable also, probably by chemotherapy for liver cancer, but also for Claudin 18 ARH gap fusion by antibody developed against Claudin 18. Thank you very much.